Good morning. Welcome everyone. It's lovely to see our board together for the first time in 2023. My name is Anita Day. I am Chair of Worcestershire Acute, and this is a meeting of our board in public on Thursday the 13th of April. As I say, it's nice to have everyone together in one room. As colleagues will know, it is my want to start the meeting with a reflection on our values, our purpose. And I want to just talk a little bit about the thing that we talk about a lot, about putting patients first. It's a phrase we use a lot, but actually it has lots and lots of different meanings. It could be the case of a healthcare assistant or a nurse on an inpatient ward, noticing that a patient perhaps doesn't have any visitors, is looking a little sad or lonely, and taking a few minutes to sit with him or her and chat to them and get to know them a little bit. It could be about a booking clerk who is booking a patient in for some treatment, who remembers our very successful initiative about #CallMe and makes the effort to find out what is their preferred title, their preferred address, and make sure that that's captured in our system so that all our colleagues will know that. It could be about a theatre team who have been working, who regularly work long hours, stay late, to try and do the best they can to get through their list for the day, and do that regularly, often without a great deal of recognition and often without a great deal of compensation either. But they do it because they're trying to get their patients through their treatment as quickly as possible. Of course, conversely, it could also be that theatre team who are exhausted, who've been working flat out all day, and who make the decision that actually it would be safest for the patient to defer that treatment to the following morning rather than try and push it through when they're tired. And then, of course, it could be a group of staff who are very conscious that their working conditions and pay are such that it is dramatically impacting our ability to retain staff or recruit them, and therefore feel that they put patients first by highlighting that to the government and to the centre. We all around this table know that we are currently on day 3 of the latest industrial action of the BMA, which involves all doctors in training below the level of consultant. I'm not going to use the term junior because many of them are not remotely junior. I've got really 2 messages to say about that. The first one is I want to give our board heartfelt thanks to every single member of our team that is going above and beyond to do what they can to keep patients safe at this difficult time. There are many, many staff, consultants, physios, pharmacists, all our staff. Some of them are taking on additional responsibilities. Some of them are having to work in completely different areas. Thank you so much for doing what you can during this really difficult time. My second comment, though, is to the centre, to the government and the BMA. This cannot continue. The risks that this poses, not only to our organisation, but to all organisations in the NHS, are such that we cannot allow this to continue, because even if we manage to keep patients safe at our organisation over these few days, nationally, it is almost inevitable that some patients will come to harm. I absolutely urge the government and the BMA to do everything in their power to resolve this dispute as quickly as possible. In terms of our meeting, I have apologies from several people today. Neil Cook, our CFO, is away, and we have Joe Cohen. Joe Cohen is deputising. Joe Newton is away, our Director of Strategy and Transformation. Lisa Peaty is deputising. Tracy Pearson, our acting COO, is absent, and we have Alex Borg deputising. And Jackie Edwards, our Chief Nursing Officer, is absent, and we have Sue Smith deputising. Welcome to you all. In terms of items of any other business, I haven't been notified of any before this meeting. Does anybody have anything they would like to bring to our attention? I don't see any comments, so we'll move on. Declarations of interest. Obviously, our general declarations are on the website. In respect to this specific agenda, if anyone has any declarations, please make them now. No, thank you very much. Moving on then, let's move to the minutes of the last meeting, which are in your pack now. I wonder if I could have your either note of any corrections or clarifications, or indeed your confirmation that that's a true record of our last board meeting in public. Does anyone want to raise any concerns about any part of those? Are we happy to take those as a true record? Thank you very much. Right, then, moving on, the action log. Rebecca.
Thank you, Chair. The action log is updated as per the pack, and we're in the process of recasting the board development plan. Thank you.
Any comments? Simon.
The one everybody's got used to now, just an update from Tina on how this is sort of practically making a difference to colleagues' lives. I know there's a reference in the minutes to the new strapline, which I think is great. But I know it's an interesting process, so if there's anything you can add in terms of how specifically they feel like they're discriminated against for whatever reason.
We are still working on processes to make sure people are my HR more and then across every business and across all of our sites. Make sure people are aware of those posters up and leaving materials there. We have got a steering group to oversee the implementation of our behaviour charter that meets regularly, and we review progress against that at TME and People and Culture Committee. So it's still early days to see that difference.
Thank you.
Thank you. Right, I'm moving on then. I don't have anything to report, so I'll hand over to Matthew.
Okay, thank you, Chair. And thank you for your words at the beginning of the meeting. I think it's really important that we, despite not having necessarily a patient story for today's meeting, really centre the conversation that we have today in the importance of putting patients first, and our strategic pyramid focused on the vision of working in partnership to deliver the best outcomes for patients that we serve. So with that in mind, first up in my report, and unfortunately is to note my securing the new job. Anita and I are working through the timescales for my and the succession arrangements, which will be able to report in due course. But I thought it would be important to thank everybody around the board table for your support over the last 4 and a bit years, and the progress that the organisation has made with patients and with our partners and members of the public during a period of time, recognising there's still more to do. So a particular nod to my executive team not to take the foot off the pedal as we progress into this year's annual plan, which will be inevitably touching on through the course of the meeting. I suspect we'll come to many of those points later on during the meeting. Chair, you referenced the industrial action. We're on well into day 3. The planning that's gone into mitigating the risks for patients and mitigating as best that we can the impact on patients that were coming in for planned care during that period of time seems to have gone very well. We have had, on average, about only a third of our trainee doctors in an aggregated trust-wide position turn up for work. But our arrangements, particularly with our consultants and other healthcare professionals, as you referenced, Chair, we've seen a number of people go above and beyond in maintaining patient safety coming in from annual leave. One of our most senior physicians is in the midst of a 3-night stint. Dr. Ling should be particularly referenced for covering night shifts. I won't say at her age, but I just said that. She will thank me for that in person. So planning has gone well so far, but the toll it is taking on our staff and particularly our management teams who've been into the plan cannot be underestimated. So I'd echo your words, Chair, that this cannot go on. There needs to be a resolution and compromise found. And of course, it's worth noting that the RCN ballot to accept or reject the pay offer closes tomorrow. So we will learn during next week the outcome of that, and that may signal further industrial action, or it may not. But we wait with bated breath to see how that plays out, because of course. All of this preparation is on top of busy day jobs for the teams concerned, and as I said, it is untenable for this to continue. Draw attention to an item later in the meeting. I won't steal Sue's thunder, but it's a good news story in relation to the progress that the organisation continues to make, and a recognition that we've acted quickly on some of the CQC's concerns and resolved some of the points that they suggested we needed to address, whilst at the same time recognising and applauding the leadership of our urgent care team, Dr. Dave Raven, Claire Bush and Wendy Jobin-Saris, for their extremely good leadership to move, despite continuing challenges in urgent care, to move the CQC ratings into a positive place. So really recognise the work that they've done. We're obviously into the new financial year. The annual plan for 23-24 continues to be in discussion with our integrated care system partners. Those of you that are avid readers of Health Service Journal and other rags will know that there's been a lot of concern about the overall picture of the NHS finances in this financial year, and a number of ICSs have been asked to review their positions, and that includes our ICS. So clearly the discussion and conversations about creating and setting a realistic, achievable plan are very much part of the ongoing conversations that we're having with our system. And just to draw attention to one of the points that was raised at a previous meeting, from a patient story, there has been action to resolve that in fairly quick order to make sure that our patients with from the deaf community are better cared for. And then just finally, the time of writing this paper, Chair, we were obviously coming up to a number of, or in the midst of a number of religious festivals. So warm wishes and to all those of our staff and patients that are recognising those religious festivals during this time. So happy to take any questions, Chair.
Any questions?
Thank you. Thanks, Matthew. You talked a little bit about the annual plan already. I'm not sure how extensively it will be discussed in other points. You say RICS has been asked to reconsider maybe some elements of the plan. Do you have any idea of the size of that and of the timelines related to that?
Yeah, so we understand that active conversations with some integrated care systems with the Director of Finance for NHS England are underway at the moment. That doesn't actually include RICS, but the discussion around the size of the planned deficit for Hereford and Worcestershire is an area where there's been a particular focus. Two areas where there's been a request for further improvement in the plan is around agency spend, and that's across a number of providers in the system, particularly those that are using high cost agency, which of course from a nursing perspective we rarely do. And there's also a particular focus on productivity and the size of the cost improvement or productivity programme as we describe it. A number of organisations are pushing 5-6% in their plan. That's, in my view, unrealistic. We've set out our stall to aim for just above 3%, 3.2%. and we will, as we always do, develop plans that are stretching, are ambitious, but are realistic and achievable, as opposed to something that I think is going to cause difficulty later in the year. So I think those are two of the key areas where there's been particular focus. I think the third area is on the three key performance priorities. We've, as colleagues will know, we've submitted a plan that we believe will be compliant with 65-week longest waits for patients. By the end of the year, we've submitted a plan that we believe will deliver the cancer target at year end of 190 patients, which is still a lot, waiting over 62 days for definitive treatment. And as a system, we've submitted a plan that delivers a 76% 4-hour target of emergency care standard performance. Of course, that is heavily caveated on the need for timely discharges, reduction in demand at the front door, frailty pathways and other elements that will make a difference to many of the patients that we see coming into our hospitals that perhaps could be cared for elsewhere. So whilst our plan is, as an ICS, is compliant, there is still a particular area of concern around the level of risk and the importance of reducing risk in that plan, which of course we as an organisation and through the Finance Performance Committee have discussed that risk profile ourselves.
And the timing, Matthew, when do you think you're going to close the planning stage?
Yeah, so there is a number of colleagues have picked up that there is a suggestion of another submission date. I think that's unclear at this point in time, but I am attending the National Leaders meeting next Wednesday, where I suspect there will be quite a lot of conversation and discussion about this year's plan, whether there's a further submission required. So very happy to share that information with colleagues so that people are aware of particular timescales.
Great.
Chair, thank you. Matthew, can I ask go back to the industrial action? You rightly focused on staff health and wellbeing and patient safety. And if you could comment on loss of activity, especially on elective. I mean, the stories in the press around how many patients will not have been seen through planned cancellations as a consequence. I wonder if you could comment on what the Trust's position is likely to be after the event in terms of how many lost opportunities have been for patients to be seen or treated. Thanks.
Yeah, so the teams have, as with the last industrial action, aimed to reduce as best they possibly can the number of outpatient appointments and operations that have been changed or reduced or rescheduled. We certainly have lost and had to cancel a number of patients that had already been waiting over 78 weeks, and that totals in the 40s. But of course, in terms of the numbers of patients that would have been coming to outpatient appointments, we perform 1,500 outpatient appointments every day. The actual numbers of those clinic appointments and diagnostic tests, we don't have the accurate data on that until a number of days after the end of the industrial action, but happy to share that in future. But certainly the teams have worked hard to mitigate the impact, but for every patient that is rescheduled, that impacts on 2 patients, because of course that patient is rescheduled into a slot that another patient could have been booked into. So we are very mindful about reducing the impact as best we can. But when you only have, in certain specialties, 20% of your trainee doctors coming into work, that is a significant impact that can't be underestimated in terms of the impact on patients. And obviously we've prioritised the essential services, emergency care, neonatal care, intensive care, and so on, in order to maintain patient safety. Every industrial action hasn't the impact on planned care, and of course within, as we know, the impact of the COVID pandemic was significant for planned care patients, and this is now continuing through every single industrial action where we have nurses or doctors impacted is again impacting on patients.
Thank you.
Thank you. Any further questions? No? Thank you very much, Matthew. Let's move on then to the next paper, which is about provider collaboratives. And
Lisa, she's going to take it from there.
So I'm going to take the paper as read. Paper is for noting. The purpose of providing this paper to Data Board is just to provide a summary of our work to date on provider collaborative arrangements and where our current work is focusing. So there's further information in the reading room, but if I just give a very high level outline of what's in the paper. I think it's just worth highlighting that a provider collaborative is any partnership between two or more NHS trusts for the purposes of benefiting their populations. So those collaboratives can take a variety of forms and a variety of scales. The idea is that we benefit the populations through, for example, reducing health inequalities, that we improve our service resilience, that we improve access to our services, and also can improve recruitment through those collaborative arrangements. Government in 2021 mandated all trusts to be part of a provider collaborative arrangement. You'll notice from our clinical services strategy that in 2019 we identified that as one of our intents, and that has been strengthened through our work through the 3-year plan that we published back in the autumn of 2022. I guess if we just go back prior to COVID, boards, those who were on board at that time may remember some work that we did around our cancer pathways, our specialist cancer care with tertiary providers, and how we strengthen those pathways for our cancer patients, particularly through collaboration with University Hospitals Birmingham and Coventry. Some of that work has been superseded by COVID. It's looking to reinvigorate that work post-COVID. I guess to note post-COVID, we have signed the Memorandum of Understanding with the Health and Care Trust, commitment by both boards to work together under that MOU, particularly around international nurse recruitment, around stroke pathways, and also around some of our staff wellbeing work. Some work ongoing with Wye Valley Trust in Herefordshire, particularly around our clinical services and building on our 3-year plan self-assessments to identify opportunities for collaboration and access for patients as well. The plan there is to bring a memorandum of understanding through to both boards in May of this year that will kind of set out the context for that work and the way in which the two trusts might envisage working together. I guess, in addition, we've had some long-standing networking arrangements in the trust around certain specialties. So, for example, cardiology, imaging networks and pathology networks that are long-standing work and linking to the region as well. So I guess the work that we've done today provides a good platform from which to build and to which to seek to develop and mature our provider collaborative arrangements. But in doing that, I think I probably just want to reference some of the national work around some of the national good practice, and that would suggest that for those collaborations to be successful, we have to have a clear statement of intent, a clear scope in terms of what we want to achieve, and a willingness at all levels from board through to board to work together. Thank you, Chair.
thank you, Lisa. Any questions or comments?
Two points. Linked. It's a really helpful setting out of the basis of this development, Lisa, so thank you for that. But what is your assessment and your colleagues' assessment of the strength of evidence behind the very bold statements government are making, which are saying essentially, if you collaborate, these are the benefits? So what practical evidence is to show that that is actually a valid statement? And linked to that, I have a very old-fashioned view that structural change by itself doesn't do anything really. It doesn't impact performance, doesn't impact on the experience of patients, unless it's supported by a change in attitude where it's necessary. And I think that whilst we pursue this path of enhancing our collaboration with other partner organisations, it would be really helpful to get your views on how we will mitigate the risk of sort of not invented here behaviour by individuals who don't want to change for whatever reason.
Okay, I think those are helpful questions, Colin. So in relation to the first one, I think if you look at the pack that's in the reading room, there are some examples of good practice from elsewhere in the country, particularly around the Black Country, and, through some of our partners with the SWIFT group, the South Warwickshire Foundation Trust group, which demonstrate the benefits of working together around specific pathways and specific specialties. So those are set out in the pack in the reading room, and happy to talk through some of that detail at some time, Colin. Just in terms of the arrangements more locally, I think you're absolutely right. There does need to be a willingness to work together, and I think that's where if there's an imperative, it's important that people are behind that imperative, and that people are committed to the changes that are required, both culturally, behaviourally, and from a clinical and operational perspective, to make those changes, whether they're individual pathways or whole specialties. I guess picking up on what you said, they don't necessarily need to be structural changes. The paper outlines a variety of forms that provider collaboratives can take. Some of that might be mutual aid, and we saw the benefits of that mutual aid through COVID, whereby we were working more collaboratively with local trusts to support that COVID effort and ensure we service the needs of patients in the trust with COVID. So there are a variety of forms between that and for structural change that a provider collaborative can take, and I think each collaborative needs to look at each specific example to find what shape or form that would be. But I guess what's important is that we don't wait for a crisis for us to be able to collaborate. We want to be proactive in what we're doing rather than reactive in what we're doing. So I guess the work that we've been doing around the 3-year plan in terms of the specialties, doing their self-assessments, helping us to be proactive in terms of where would we benefit patients to collaborate, where would that benefit perhaps our efforts towards recruitment, and how can we be proactive in getting those collaborations up and running to the benefit of the patients and of the county.
Can I just come back on that a little bit, Mary? I think I heard an offer, Lisa, of you talking through the case studies that are in the reading pack. And I think that would be really useful if it focused on outcomes, because what I've only read the superficial information that's in this paper, of course, but there may be more stuff behind it. But a lot of it seems to be actions that are taken in terms of setting up a group of 4 acute care units and putting a single lead over it and so on. So fine, that's all good stuff, but what actually changed as a consequence of that would be really helpful to understand.
Okay.
Oh, sorry, Christine. For me, it's about clarity of purpose. What is the purpose of collaborating? So some of the provider collaboratives I've been involved in the past have been focused either on, for example, on sharing resources, so procurement, back office function, as HR, teaching and training and so on, and they're set up with a clear purpose to do that. Other collaboratives may be around particular services or patient pathways, and again, if the purpose is to streamline the patient pathway, to remove barriers between patients moving between organisations, to share, for example, waiting lists so patients get treated more promptly. I think that's another very useful collaboration and can be shown to have beneficial outcomes. But for me, before embarking on any collaborative arrangement, you need to be clear about what the purpose is and what the benefits you're trying to achieve for the patients.
Absolutely. Simon.
Yeah, very much back that up, and I think also from a staff point of view, I'm interested in how our collaboration with other partners helps incentivise our staff, develops our staff. I certainly wouldn't want to get into any arrangement that put our staff off or made us less attractive to recruit and retain staff. So I just wonder, in that reading room pack or other things that of, Lisa, other of outcomes that we're looking for. For me, one of those would be obviously patient safety, and patient care comes first, but very quickly behind that, how is this going to help our staff develop? How is it going to make us more attractive? And recruit and retain staff?
Yeah, so there's certainly example in the reading room around some of the Black Country trusts where they have some specific specialties, and that has aided recruitment to some hard to recruit medical posts, and through them providing kind of more of a networked arrangement across those 4 trusts, kind of have secured retention to some of those other clinical posts as well.
That's good, and as I say, the flip side of that is we wouldn't want to be getting into anything that would putting people off going to school, or heaven forfend, taking staff who are currently here for on time to move on.
So nationally, it's shown to aid recruitment.
Thank you for the paper. I think a useful discussion. I mean, clearly, we are absolutely an organisation that likes and sees the benefit of collaboration. But I think picking up on some of the points, we need to be clear about what our purpose is in collaborating. And as others have said, that our focus on patient quality of care, safety, and of our staff, the impact on staff are always going to be top of our mind in any discussions we might be having. Thank you for that paper. Sorry, Richard. Sorry, Richard.
No. Clearly agree with everybody on purpose, and we've always said partnerships are really important by of our strategy in the first place. I'm just asking the question here, so I've heard a few examples there in the document. When I look at our challenges as a trust, what do you feel is the most important partnership to really go after? And so, because we put our energy in these types of things, right? And we put energy in lots of things. I'm really interested in what we should be focusing on if we wanted to improve the let's say, the outcomes for our patients and the operational performance.
So I think that's a really difficult question to answer, Richard, because I think the answer will be different according to which service that we're looking at. If you look at the national guidance, there's a clear drive towards integration of services, which would then kind of point more towards further collaboration with the Health and Care Trust along some of the pathways that we would know would benefit for some more of that collaborative, integrative work. I guess if you look at it from a service sustainability perspective, then collaborative with another acute trust might be more appropriate. So to say the answer to that question will vary according to kind of the purpose of the arrangement and the problem that we might be trying to solve through a collaborative arrangement.
Okay. Let's leave it.
Right, thank you. I think we'll leave it there. So thank you very much. If there are no other questions, let's move on to the next paper. But thank you, Lisa. Our next paper is about the CQC inspection report, and I think Sue's going to talk about this.
So just go through the highlights of it. But following an NHS visit in November 2022, the CQC have published their final report on their website on the 6th of April, after us having been it on the 30th of March. The key points from that is there's no change to the overall trust or individual site ratings, which all remain and requires improvement. However, the good points and the good news from that is both EDs have all their inadequate ratings removed, and they've been upgraded to require improvement. So what that means for the trust is there's no longer anything rated as inadequate across any area across hospitals. We had a couple of main areas for improvement just to pull out. One was about our discharge managers and the use of those against our SOPs. So we have already submitted a significant action plan to the CQC and undertaken a number of actions to improve those. We have actually changed the management structure, so they're now sit within a division, so with real focus on all of this and mitigating those. Both discharge managers on both sites have moved areas, so we're there and no longer have patients in an advantage scale. It's a really good step forward. The other main area is to look at the medical management. And again, we do a lot of work with group pharmacy, a lot of training, especially around control, especially on discharge. So that work actually increasing. All our stuff is to be reviewed, and it's all actually down to a weekly quality check. The make sure improvements in action completed there. In the report, in the pack, there's a lot of positive findings which have been listed, which is really good to read. And that left in our sixth must do very much cover those main areas and obviously our which we also decided on and keen to improve. So saying that, we're due to submit the action plan, the CQC, the final action plan by the 19th of May, but confident that a lot of the actions that we submit will actually be completed or underway.
Taking any questions? Thank you. Any questions?
It's not a question, but it's a comment, really. So for both our emergency departments to be rated as good, but effective and caring, given the operational pressures that we're under, the fact that we have patients being cared for in our corridors, the crowding in our departments, and the pressure from the constant queue of ambulances that we often have, I think is a remarkable achievement for our staff.
Completely agree. And I think, you know, an inspection unannounced in November when we know the challenges for what they were. Yeah. I think actually to have all the, you know, no inadequates and those I think it was a phenomenal achievement actually, and we absolutely should you know, congratulate the teams. I think that was a really outstanding outstanding result. And I'm also really delighted to hear that the progress we're making in terms of the recommendations as well. I think that's excellent stuff. So any further questions? Sue?
I would entirely echo what Christine said. I think that's extraordinary. I mean, one of the things that they've identified further improvement is corridor care should be made more dignified. I wondered if I actually walked down there and wondered how you could possibly do that. I don't know how you could. I mean, it's setting something you're required to find an action plan. I mean, I walked down there. You can't put screens up.
No, it is very difficult because people are in corridors. But actually, we do use the screens. We have certain rooms in each ED department where people can be taken to be examined and talked to privately. So, and we did over bank holiday weekends. We're concerned about this. We did audit of 2 patients in the department, each department each day. And actually the patients reported back to us, I think it was about 90% found that their privacy and dignity was well catered for. So that was really pleasing to hear that with all those pressures, we were still able to do that for the majority of our patients.
So what do you think provoked them to say that? Because clearly we don't catheterise people in the corridor. But I mean, what do you think provoked them to say that then?
To say that they were happy with...
No, I'm sure the patients are, and I've got family experience of being, you know, recognising that good people do the best they can in a bad place. But I wonder what made them provoke them to say that. I wonder what they saw, all they saw.
If you go down to the department, it's actually to be faced with an overcrowded department. Actually, when you go and look, it does look overcrowded.
Well, it is,
yeah. But actually, I suppose what they don't see is actually those patients being taken away from that area.
Yeah, that's what I wanted.
They're counted for.
So we can.
But I think the general view is, you go down and you see what it looks like.
Thank you, Simon.
Say something else, but I'll just remind you of the story that I was told of somebody who was moved from the corridor into one of the bays and had to be moved back to the corridor because she was bored. I was just going to say, are we able to ensure that colleagues in those 2 EDs are aware of what we said here today and how grateful we are for the efforts they've made and how pleased and proud we are of what they've done?
Yeah,
yeah, very much so. Simon we repeat once again our thanks to the teams. I think also it's worth noting that the point that Sue made around the discharge lounge, where I know some non-exec colleagues have met with the leadership of the discharge lounge in its former guise. Not only have we seen, I think, a change in the leadership and the approach, but also and so people feel better supported, but also we're seeing a higher use of the discharge lounge in its new environments, which means that actually that's assisting flow more effectively. So I think we we knew we needed to do something. This has pushed us to make some changes, and I think patients and staff are benefiting. But we'll certainly feed that back, your comments and those of other board members to the leadership team for urgent care and the team that are now responsible for the discharge outcomes.
Yeah, please do. Tony.
Thanks. Can I ask about the level of confidence you've got in the resilience of the action plan? Because I've been in other trusts where the response to the CQC has been swift and on paper looked good, but when it was unpicked later in the subsequent inspection, it hadn't held up because a lot of resources gone into it, which had sustained it on a temporary basis. But the level of confidence that these changes are sustainable, permanent changes, please. Thank you.
So what we've done previously, we had RAPE meetings, so our rapid improvement meetings, and each division takes its must-dos and should-dos from the report and actually devises an action plan for the division. And actually what we had was confirm and challenge meetings every month, which the CNO is preparing to put into diaries. And actually that's actually monitored every month then against the action plan. So actually we'll be able to actually measure that sustainability, because okay, you can do the actions initially, but how do we go? But I think that's about monitoring how we're sustaining that. But actually we're going to go back into our RAPE programme to do that.
Yeah, some of the changes we've made to medicines management in the discharge lounges have been driven by the forward improvement system. So we've used that methodology to make the changes that we needed to do to improve our medicines management. And we know that changes that we make using that methodology are more sustainable than top-down or other methods of making improvements.
Great, thank you, Christine. Any other comments? No, as I say, overall, thank you for taking through that. This is absolutely good news for me, and we would please encourage Matthew to make sure
the gratitude and reward for the work that's been done here, I think is genuine. Lovely. Thank you very much. That was for assurance, level 4. I think we're happy with that. Let's move on then to the next report, which is the performance report. And I hand over to Vicky.
Thank you, Chair. Good morning, everyone. This is the integrated performance report for month 11, and it's here for assurance. It's been approved at our Trust Management Executive on the 22nd of March, and it's been through the various subcommittees of the board and been assured. It has an overall assurance level of 4, and that remains unchanged. We've picked out highlights around operational performance, quality and safety, people and culture, and also our financial position, which each individual director will talk to. However, I would like to draw your attention to page 56 in your pack, which talks about some headline successes, particularly around our cancer performance and also our 104 plus week rating, which there was 0. And I'll pass to Alex, and hope I've not stolen your thunder there.
Thank you very much. I appreciate that, Chair. I'll just look at some highlights and talk a little bit about current performance as well as the performance that the report. If I can start with cancer, I think we've made some really good progress there. At the time of the report, we had 418 patients over 62 days. I'm pleased to report that at the end of the year, we finished at 243. That's clearly 243 too many, but does represent a significant improvement against both our previous performance, but also our revised recovery trajectory of 328. We remain really challenged in urology. It is urology alone that's keeping at tier 1. Urology now represents 60% of our entire backlog, so there are obviously some very key challenges there. There are some actions that we're working through, which I'm very happy to go through. But now what I will say is that notwithstanding the challenges, we have seen some improvement there. So the backlog today in urology stands at 143, so significantly better than where we were. And I think of note, our mean time to treatment in December was 106 days. As it stands today, that's 67 days. So again, some way away from where you need to be, but does represent, I think, some improvement. Just to compare ourselves to some peers, in January we were rated 19th out of 23 organisations in the West Midlands. Today we are 15th. So again, not what our ambition would take us to, but again an improvement compared to where we were. I'll stop there with cancer and move on to RTT, if that's okay. So at the time of the report, we had 713 patients over 78 weeks. We were forecasting circa 400 patients at the end of the year. We ended the year at 350. That position isn't validated, so it will come down, but only slightly. So we'll be in the 330 to 350 range. Again, that isn't where we want to be. But if you consider our modelling in March of last year, it was over 1,200 patients we had forecast in that cohort. I think moving forward, we've got a very big challenge, clearly, in terms of hitting 65 weeks. As it stands today, there are over 44,000 patients that potentially could reach 65 weeks at the end of the year if we did nothing, and that's a very important note. Of those, 27,000 or just over are at risk of reaching 78 weeks at the end of the year. The main challenges, won't be a surprise to anybody, general surgery and gynecology. We've just established an elective recovery task force supported by NHS England to keep a very close eye on that, and I'll be heading that up initially, and indeed our first meeting is next week. In terms of patient flow, again, colleagues have referenced some challenges. We continue to struggle in terms of ambulance, particularly on the Worcester site. Again, at the time of the report, over 700 over 1 hour delays to offload. That's still an improvement compared to where we were, but again, doesn't reflect where we'd want it to be. And we had 283 patients over 12 hours, which again reflects a position that none of us would want. I'll stop there, but happy to take any questions.
Thank you, Alex. Any questions or comments? Karen.
Thank you. It was just on patient flow, and it's commented in the paper about the impact, understandably, of COVID and D&B and the bed closures. And it talks about nearly 160 beds closed due to that. So, if I'm so I just wanted to get a sense of what percentage is that across all sites, or was that just at Worcestershire? So what percentage, and also where does that sit in comparison with other trusts in terms of the ratio of closures for those reasons?
Across both sites, it's about 30-ish% of the total bed base, if I'm not mistaken. But I don't know where that compares to the other organisations. That's something we can find out, but I'm afraid I wouldn't know at the moment.
Thank you.
I mean, it's worth noting that at this point in time, we're peaking well above 100 inpatients across the two sites with COVID. So it was predicted there would be an end of March further wave of COVID-19, and we've seen that. Now, obviously, some of those patients are incidental findings, but we do have patients coming in sick with COVID again. I think peaked earlier at the end of March with about 17 outbreaks of either COVID or norovirus. So the impact is quite significant, as you pointed to, on patient flow. And I'm sure Alex will find out how that compares with other organisations. But the COVID impact is problematic.
Thank you. Colin.
Thank you, Jen. I welcome the good news on cancer. I guess the obvious question is, how confident are we that it's sustainable progress? I was particularly interested in the comments under what we're doing next around seeking independent sources of treatment for patients and perhaps out of district. So how's that going?
Okay, so in terms of the sustainability first, in the main, fairly confident. There are a couple of services I am concerned about and do need some further consideration of thought. They are dermatology. They're referenced in the paper from Lisa with regards to one specialty that I'd considered to be risky, and we're working wider across the ICS in terms of solution to that. We've had some challenges with recruitment, and we rely very heavily on the independent sector, an organisation called 18 Weeks, and that's an area where we're doing okay at the moment, but there's always that risk. The other being urology, and that's largely a workforce challenge, as I mentioned earlier. In terms of the support more widely, it's going reasonably well, and actually with urology, it's probably a really good example to go back to the discussion we were having earlier around provider collaboratives. we're working more collaboratively with Wire Valley in particular, could enable us to ensure that patients are treated quicker. They have a robotic surgeon are in the process of commissioning a robot on that site. They do not have a waiting list, and so we're in discussion with them around how we ensure that patients across the ICS are treated quicker right across the board. We have some expertise that they don't, particularly with regards to open surgery, so we're exploring how we might work collaboratively together. We had our first 2 patients go to Northampton last week for an outpatient appointment, and they're going to be having surgery on either the 23rd or the 29th of April, depending on their surgeon's availability. It is difficult when patients have been with us for a long time to then suddenly suggest to them that they might want to have their treatment elsewhere. And so we're exploring how we might be able to offer that as an opportunity much earlier in the pathway at the time that they are potentially listed for surgery. But there are a range of organisations that potentially could help us, including UCL in London, for some of our long waiting open patients awaiting open prostatectomies. The other areas are Northampton, which is an NHS trust, and then HCA, which is a private arm of the Christie.
Thanks. A couple of questions to come on to. First, I think it is worth just reflecting on the progress we are making with cancer. Yeah. We look at our regional benchmarking for 2-week waiters with 2nd out of 13, for 2-week waiters for breast symptomatic with 3rd out of 13. So progress has been made, which is great to see. I know we still have challenges on some of the data-related targets, but it's sustainability we're looking for. Questions around people who don't need to be in the ED. I know we have a figure of 8,743 who self-presented, and a reference in the papers to an estimate of 16% of people maybe not needing to be at our EDs, and we're working with the system on how we can find alternative treatment pathways for them. If you could give us an update on that, that would be helpful. There's a reference also to the beginning of planning for 23-24 winter pressures with the system, and again, it would be helpful to know what we're talking about there and how that's going. And then I also noticed a reference to flow and neck of femur fractures this time in the report. And again, I don't know whether I've seen that, but if I'm looking at Christine, whether that's been an issue before. But it struck me something I hadn't seen before. So any comments on those, Alex, would be great. But I'm always interested to know with those who may not to be at REDs in the first place.
Yeah. Thank you. I mean, I think that's a really good question. It's a challenge though, because as a patient, you'll always go to the place with least resistance, and it's for us as a system to both ensure that the alternative places of care are available, but actually that they're easiest to access as well. It's all very well sort of establishing something, but if it's easier to come to an emergency department, then understandably that's what people choose to do. The discussions are still ongoing in terms of alternatives. There isn't anything really firm that I can update on unless Matthew's in a position to do so. But I think the key challenge for us is about ensuring that those alternatives are really the easiest for patients to access moving forward.
Yeah. Let's just get to the fraction of the theme bit, and I'll get you to finish it.
Yeah. So in terms of fracture neck of femur, our performance at 78% of patients getting to theatre within 36 hours is actually the second highest performance that we've had over the last 12 months, and reflects the continuing commitment of our trauma and orthopaedic teams and all the support services to make improvements in that pathway. So they're still working through the action plan that they themselves developed when we had an improvement away day at the end of last year. The main cause of delays for those patients who didn't get to theatre within 36 hours is trauma theatre capacity, which reflects the sheer amount of trauma that we've had coming through the front door. We are addressing that by, where possible, directing patients to same-day emergency care with ambulatory trauma surgery at Kidderminster for the ones that don't need to be admitted as inpatients, beds on the trauma unit remain an issue as well. So that's fractured neck of femur. It's not just that pathway that the front door pressures impact on, because you will also see from our report that sadly our snap board has fallen to a level B, whereas we were very proud that it had been consistently maintained at A prior to that. The main reason for that is a reduction in our ability to get patients to the stroke unit within 4 hours. The clock starts when the ambulance arrives outside our emergency department. So despite the fact that our stroke teams are going and assessing patients on the ambulance, if necessary, they're thrombolysing them in the emergency department rather than waiting to transfer them to the ward. So they're still getting the treatment, but because of lack of capacity in the stroke unit, we're not able to get them consistently to the ward within 4 hours. And part of the issue with that is that, for example, as of today, we've got 10 patients within the trust awaiting a stroke rehab bed at Evesham, and no capacity at Evesham to transfer them there. So again, we're looking for a system response to support that.
Thank you, Christine, and I wanted to ask about the stroke as well, so your comments, that's great.
Yeah, thanks, Chair. Just, Simon, in terms of the pre-hospital question, I think the key additional tool in the toolbox that perhaps not the best metaphor to choose anyway, it hasn't yet come to fruition is virtual wards. So there's been a real focus nationally on creating virtual ward facilities in order to avoid patients being brought to ED due to a combination of capacity and workforce challenge, medical capacity and nursing workforce challenge and vice versa. Virtual wards haven't really got going yet. So those patients are being brought in where ordinarily they ought to be being cared for in community settings. And we're also seeing a continuing situation of patients being sent to ED with letters where they ought to be being referred to same-day emergency care, etc. And that's even through this week's industrial action, we've seen that happening. So I think those will be the two areas that we'll be focusing on through the system urgent emergency care board.
And there's a community beds as well. How's that going?
I think we've seen the discharge data shows that we're getting closer to hitting the target numbers consistently. At the Alex, we're delivering that at the Worcester site, getting closer to it. But there are times when our operational teams are finding that criteria to admit patients into community beds is perhaps less flexible, particularly on the infection control side of things, than it needs to be. And we're enlisting our integrated care board, medical leaders, influencing a more flexible approach to accepting patients into community beds in order to make best use of capacity.
Thank you, Matthew. If there are no further questions on that part,
Sorry.
Richard.
So first of all, I'm also really happy with some of the progress that we see in cancer. I think also in theatre utilisation, we see some good progress. Clearly, Alex, I understand what you say about 78 weeks. It was 0, obviously, and so we're still far away from the target. 65 weeks is going to be extremely challenging as well for next year. So I'm really interested in what we're going to do and ensure we actually achieve those targets. And I know there's a number of dependencies that we put in our plan on initiatives elsewhere. And I think it is really key. We know those dependencies and we measure against those dependencies. And them have just been discussed. Second point is, I think we tend to forget that our performance is heavily influenced not just by the amount of COVID patients in the wards, the outbreaks we've had through, but also by the strikes. And I think it would be worthwhile to better understand what the effect has been on our performance in that. And then finally, the thing that I'm probably most disappointed about is the front door performance. ambulance handovers. We've invested a lot, both in terms of flow and in extra capacity, and I'd like to understand what's the cause of that, what is the effect of the extra capacity we brought on board, and how can we fundamentally change?
Okay. If I start with the 65-week, we're absolutely right. So the target was 0, and it's going to be a challenge. I've got a quite significant tail. Obviously, there are patients currently who end up being in the cohort of 78 weeks. And so the challenge is significant, particularly in those two specialties I described earlier, gynecology and general surgery in particular. So the range of actions that we have been taking on our ramping up, that includes how we utilise our own resources better. So you referenced the utilisation there. There's obviously an improvement working on in outpatients as well, because that's an area where, again, there are some opportunities for improvement. And then there's the use of the sector and how we maximise capacity that's available, both locally but also wider than that as well. And the establishment of the elective recovery task force that I described earlier, and bringing together some key individuals from across operations, finance, and so on, just so that we can keep a real tight train on that. There's a whole bunch of work that we need to do around data quality and validation as well, because it's important when you're seeking to address a challenge like this, the waiting list is as clean as it can be. So there's a whole range of avenues and actions that we're taking that we need to ramp up. So it's about, in some respects, doing more of what we're doing now, but recognising that we're in April now, we've got till March next year. And so really getting very early on handle on the additional capacity that we need. So a whole bunch of other things in terms of recruitment and retention that clearly will play a significant part, particularly in some of the challenged areas that I described, like urology, where we are significantly short of where we need to be in terms of our establishment, and so the ongoing work there to get us up to establishment is particularly important. So I think, Richard, in summary, there's a range of things that we're already doing that we need to ramp up in terms of 65 weeks. It's going to be harder still than 78 weeks. The ongoing challenge and risk around industrial action is a very real one. We likely to have cancelled between 300 and 400 outpatient appointments per day of the industrial action. Doesn't sound hugely significant in the context of the amount that we see on a daily basis, but still, when every single slot is critical, it does have an impact. And so obviously we're all hoping for an early resolution there. That's the 65-week challenge. It is going to be a difficult one, clearly, but as Matthew said, we do have a plan to get to 0. There is a lot of variables that can affect that, but we'll obviously try and manage them as best we can over the course of the next few months in particular. In terms of the front door, changes are vast and multivariate as well. So Simon's alluded to the overcrowding effectively that's caused by us being in a position where we're having to treat people who may be covered by treatment elsewhere. We still have a real challenge in terms of physical space and flow into the hospital, which is the critical one. So, every day that I can remember, the last few days I've been covering capacity, we come into 30 patients from the day before, so we're always a day behind in terms of the way we're managing our flow. Significant number of patients needing admission. That impacts then on the emergency department's ability to see, treat patients coming in and release the ambulance upload and stuff that you're describing. So in terms of the actions that we need to take to address is something around, obviously the processes within the department itself, but I think in particular it's how we ensure that we have good flow out, earlier discharge before noon in particular, and we still have a lot of discharges that are later on in the day. So yeah, a whole range of things that we need to work on in order to improve the performance. In terms of the other developments. They do enable us to care for patients better, don't necessarily give us additional capacity per se. And so it's more about how we improve the flow outside and upstream from the emergency department than necessarily the emergency department itself.
Yeah, just Richard, one to add to the points that Alex made. I mean, I think one of the key differences between the two sites, the Alex has been more resilient, and we've seen fewer ambulance handover delays there, despite actually the number of times that they're receiving divers. They tend to be able to manage their flow more effectively. And I think that's as a consequence of the relationships and the way of working, the team working that happens on this site. Between ED, the assessment areas, medical short stay, and the base wards. The Worcester site has, I think, had a weakness for some time around the site management function. We've recruited a new leader to that team who started this week. We met yesterday at my team meeting to discuss how to ensure Rachel, as the new leader of that service, is properly supported to be able to be successful, because one of the key issues has been the complexity of the routes of admission, whether it's from outpatients and so on, and some of the cultural behaviours on the site amongst the teams. So I think that's an additional point that I think will make a difference to the management of flow, particularly on the Worcester side. But we've got to make sure that new leader that's been brought into that role is better supported than we've done in the past. The key there is making sure that team are well trained, well supported, and fully established. I think that's what's going to do this. I think that will make a significant difference if we get that right. I think the other key point for us is making sure that we continue the progress that we've seen over the recent weeks in the time of day of discharge, which is now getting consistently above 20%, 22% this week. So far, we need to get that above the 25% to really start to make a difference to flow during those two key areas. I think will make a difference.
Thank you, Matthew. And Karen.
Thank you. Just back on to patient flow, if I remember correctly, patient flow is one of the value streams. And I guess my question is, which area, knowing that those things can be very broad and very focused, which area of patient flow is the value stream focusing on in order to, I'm sure, impact on some of these challenges?
So our first two RPIWs within the patient flow value stream have focused on the process of creating the discharge summary and writing the prescription for the TTO medication, the tablets to take away. Our initial process mapping and timings suggested that process from the patient being declared medically fit to discharge on the board round to all the paperwork being completed could take up to 8 hours. So we're focusing on things that we can influence, and we've put in process a whole series of changes that can take that time down to 45 minutes. So that is being embedded in just one of our wards at the moment, in line with the methodology. You embed it fully in one place before rolling out more widely across the organisation. So we will soon be rolling that out. The second RPIW focused on the time period between the prescription being completed and the medications being in the patient's hands. And again, some changes that would very significantly reduce that amount of time. So we're focusing on the things that are within our own gift to improve, rather than things that are actually very dependent on people outside of the organisation to improve.
Yeah, thank you. Can I ask Matthew? I remember about a month ago there was a system review, wasn't there? We had somebody came in to look not only at us but at other parts. Were there any outcomes from that review that we're bringing in?
So we did commission, or the Integrated Care Board, Integrated Care System Leadership commissioned a review of why length of stay had gone up in both the acute beds and in the community beds. We've not seen any findings or results of that report as yet. We've got some questions about how that review was conducted. So those need to be resolved first before we can then accept any findings.
Okay.
But so we're awaiting that report.
Okay, thank you. A good discussion. Oh, Sue,
Just really quickly on the same thing. The information's probably in here, but I can't tie it together, and particularly in relation to getting the system to understand our situation with regard to discharges. Long stay patients, the numbers of patients staying longer is going up. Actually, it's going up to hit about what it was pre-pandemic, and maybe some of that, or maybe hopefully a lot of that, reflects increased activity. The more we do, but it'd be quite interesting to see that information displayed, to see what proportion of those long stay patients were medically fit for discharge and at what time, and break that up a bit so that we can let the system know that we've got 2K over 21-day patients, and of those, how many being medically fit for discharge for more than, say, 7 days. Because unless we can keep giving this information to the system, because I think this belies the fact that we're admitting people who don't need to be admitted. But we can't show that. Well, it might do, but we can't show it. They're not in a long time if they don't need to be admitted.
No, exactly. Thank you for that. A good discussion. I would say that, again, I'd also reiterate, I think Richard made a comment about, given that the focus that's going to be on elective waiting lists, actually being able to quantify the impacts of the industrial action and building that in, I think will be an important thing. I know we all know it, but actually if we can put some numbers to it, that may be helpful in sort of our being clear about what are the things that we actually can control and those things that we could not. But thank you for that. Very conscious of time, so I want to sort of slightly quicken up. In terms of quality and safety, we've actually covered quite a lot of this already, but I don't know, Sue, if there was any other parts of that you just wanted to highlight, or were you happy with the conversation about that? Okay, that's fine. Fine. Okay, thank you. People and culture.
So the headlines are very similar to last month. We've maintained getting our basics right still, despite the COVID pandemic and industrial action around our mandatory training, appraisals, etc., with the exception of job planning, where we've seen quite a significant drop. So working with Christine and divisional directors to improve that in Q1. We're still ahead of our workforce plan due to our focus on recruitment and retention, and we'll be above that at year end. Unfortunately, some of the benefits of that we haven't seen because we're having to offset bank and agency use of the escalation areas, third areas, and slightly higher sickness absence rates around the flu pandemic in December, and also an increase in specialising for mental health patients as well. So that's offsetting benefits of our improvement in our staffing post, and then we have seen slight improvement in our staff health and wellbeing, and we continue to perform well compared to the national average. Happy to take questions.
Thank you. Any questions or comments for Tina? No, thank you. So finance again. Jo, as I say, if you could just kind of give us the highlights, that would be brilliant. Thank you.
Absolutely, thank you, Chair. So taking the report as read, so at month 11 an adverse variance of 800, increasing our year-to-date variance to 1.8 million. I'm sure those with a keen eye will see at month 11 we're at 19.3 million, and within the paper we're given the confidence around landing the month 12 position. A lot of that was on the back of receipt of additional income that we've previously mentioned. Before I give you a snippet of what month 12 actually looks like, 'cause we're in the thick of finalising it now, I think it's just worth me mentioning that those variances that we've reported here for the last few months around the winter costs, the pay award, the PEP, have continued and are presented in the same way this month. As I said, we're closing the position now as we speak, and I'm pleased to say that we're confident in terms of landing that position against the plan, which is really pleasing, all things considered, and also just references, I think, the confidence and the improvement around our forecasting as an organisation as well. Moving on to capital, so at month 11 we're reporting 25.9 million spend, with a big expectation of a further 25 million in month 12. Hot off the press with the team, we're coming in within 52k of that revised 50.7. So again, a pleasing position. And just pulling out the highlights from the report in terms of that close linkage with finance, the estates team, digital, etc., has been really pleasing, and basically has resulted in the position that we're presenting here. Obviously, those headlines that I've given are pre the audit, and when we're here this time next month, we'll present those updated numbers.
Great, thank you.
Take questions.
Thank you, Jo. Any questions or comments? I think it was Colin first. I'm sorry.
Yeah, Colin
first.
I may even be going to say the same thing, Richard. Pleased to hear that all things going well, we're going to land where we want to be. But I think it would be helpful when we finalise the position for the year end, perhaps through the meeting of the Finance Committee, to really focus on what the underlying run rate is and to what extent the outcome is as a consequence of being able to take advantage of legitimate balance sheet adjustments. But that doesn't help us with the run rate going forward. I think it would be very good to focus on that.
Absolutely, and it is something that as a system we're giving a lot of attention to, so that's absolutely, we can bring that to life through the Finance and Performance Committee.
Thank you. Richard?
Yeah, so Colin did address half of my points. I think I would echo the compliments about the financial management, really good. I think second year in a row we achieved what we said we would achieve. We might not like the outcome as an outcome, but we've done that really well. So I think that's very positive. I think the concern underlying is around how we achieved it. We didn't achieve our PEPs. We had a lot of one-off events, which means there is a not significant impact, positive impact on our run rate, which leaves a big challenge for next year, which is one of the risks in the plan for next year. And that also is clear when you look at the cost per weighted activity unit, which is really significantly higher than it was in 1920. So those are the things I think we really need to get under the skin of in the context of really being able to deliver next year's plans.
Thank you. Yeah, I think agree. But agree with the general comments on the finance that in terms of, we may not like what the numbers tell us or are, but actually having more confidence that at least we know what the numbers are and that we are managing it. I think that's somewhere that we were not, certainly a couple of years ago. I think there's been some real progress in that area. So congratulations, Matthew.
Sorry, Joe. Trying to sum up there, so apologies there. But I think Joe perhaps was modest a bit about the capital. But it's we've made a significant improvement this year in the way in which we've certainly the executive team, leaders in the States, finance and digital, have come together to make sure that the money is best used and deliver benefits for patients. And let's not forget, I think this year's been the biggest capital programme this organisation has ever had, and to land so close and effectively on target in terms of that spend has been real credit to the people involved, and has demonstrated a significant improvement in our internal governance, where we've created a strategic programme board, which I chair, which oversees the big programmes and ensures that we're mitigating any risk around delivery. And of course, whilst the new urgent emergency care department has been a long and drawn out story, This year we have delivered on time, in budget, a series of other capital programmes that should give confidence that we are able to do executive. So I think it's important just to note those points.
Completely agree, and I would add to that as well, not just the sort of the capital infrastructure, but of course the work we've done on the EPR and so on this year as well. This has been actually a year of real progress in many areas, and I think we have demonstrated some real progress in terms of governance and management of those areas. So yes, absolutely, our thanks to all the teams involved in all of those areas. Right, moving on then to...
One question, last question.
Go on, Simon.
On 136, where we have our workforce composition number, are we at the time when we should be recording 3 genders rather than just noticing the number of people?
Good point. Yes.
I think we just play around with the graphic.
You can.
Thank you.
Good point. Yep, absolutely. Thank you for picking that up, Simon. Right, moving to committee reports. Again, I imagine some of this has been covered in our previous conversation, but let's do it. F&P, Finance and Performance. Richard.
A lot has been covered, and maybe just good to talk a little bit about where we spent most of our time in the last committee, which was on one hand, of course, on the junior doctor strike and the risks to the patients, first of all, and then to our staff, but secondly, the annual plan. And I'd just like to repeat that I think the current version of the annual plan, which is still due to change, as I understand, is a very ambitious plan with a lot of risk and ambition in it. So that's the first thing. And I think the thing that beyond the fact that it's got these risks, and you cannot really isolate those risks individually, they're very connected to what we want to deliver on our activity level. The key point we discussed, which I feel is really important to note, is that whatever the outcome of this plan is going to be after all the discussion that still need to take place, it needs to be fully owned, not just by the executive team, also by the divisional teams. And so it's going to be an area of focus in whatever the outcome of this discussion.
Good point, Richard. Any other comments on regarding F&P? Okay, thank you. That's great. Quality Governance Committee, Julie, anything you want to draw?
I wanted it to be covered because at the time the industrial actions looming on the horizon, we spent a lot of time going through the mitigations and actions that could be taken. I think the rest of it, we're still going to cover or has already been covered. So,
okay, thank you very much. People and Culture, Sue.
No, I'll take it as read. We actually had a very good meeting. We've still got a way to go with our banking agency and the other work we've done on culture, but I think I'd like the board to recognise the extraordinary efforts that Tina and her team have put into getting the progress that we're beginning to see the fruits of in that meeting. So I thought it was a very reassuring meeting earlier this month.
Great. Thank you very much, Sue. So if there's no comments or questions for any of the committee chairs, let's move on. Going concern, Jo.
Okay, thank you, Chair. So taking the paper as read, and just to reference that this is the concept around going concern is a principle that underpins the accounting regime used in preparation for our financial statements. Whilst this is our 10th consecutive year of not achieving break-even duty, nor have we had to rely on cash support, the important message here is that the facility to access support, should we require it through NHS and that process does still exist. And in those years where we have had to do it, where we have applied in line with policy, those applications have been successful and granted. On this basis, we see that nothing is going to change on that front. It's been this way for many years. And on the balance of risk and the uncertainty around that it's consistent with previous years, etc. Our recommendation is that we accept our organisation as a going concern.
Thank you, Jo. I see this has been through F&P and Audit and Assurance Committee, was approved by both committees. Any questions or comments? No. Are we happy? We have to approve this request
for approval at 11.7 at a level 7. Are we happy to give approval to this? Thank you very much. Okay, great. Moving on then to staff survey. I think that's the next one, isn't it? Yes, staff survey. Tina.
Thank you, Chair. We did discuss this report in detail at the People and Culture Committee. The staff survey is mandated for NHS trusts and runs from October to November time each year. The results are compared and benchmarked nationally, and we're obviously in the acute sector. The journey that we've had as an organisation, back in 2017, we were 83 out of 85 acute trusts, so right in the very bottom quartile for our staff survey results. 2 to 3 years ago, so the 2020 results, we did see our results improve quite significantly from the bottom quartile up to just below average, and we sustained that position for the last couple of years. So we have seen some of the impact of the COVID pandemic and other bits on our staff survey results. But you'll see from the slide presented that we're not an outlier in any of the areas on the staff survey. Also, our results this year are consistent with what we're seeing nationally. Disappointingly, we've got a lower response rate than we would like, and that's something that we need to focus on and improve this year. We've also seen the same feedback from colleagues as nationally, that they're dissatisfied with the level of pay, and that's not surprising given the comms around the industrial action. A concern, I think, is the staff feeling confident to raise concerns about clinical practice, and that's to Simon's point earlier around our behavioural charter and the mechanisms that colleagues have got to raise those. And the second part of that is about the confidence that the organisations would address those concerns. So again, we're doing some further work to make sure that feedback loop is really important to colleagues. The other bit, because of the constraints that we've heard today in the meeting about resources available and pressures on our specialty areas and services, staff are scored lower for being happy with the standards of care they're able to provide, but also to recommend the trust a place to work. We did do a deep dive in the People and Culture Committee around recommending the organisation, and got some actions that we're working through to address those themes. But one good thing that came through is the strong sense of team working in the organisation. So we are seeing a shift in that culture around teamwork. So the next step on this is to get the ownership of the staff survey in the right place in the organisation. So that ownership needs to be at team, specialty and divisional level as opposed to corporate level. So we are working at those levels to develop what we're calling a culture plan, so that specifically responds to those areas of feedback from the staff survey. So they develop those actions pertinent to the areas that they need to address. And then we've got a revised governance structure in place to make sure that we have got the oversight and then able to support those improvements. And I have shared with board members the culture heat map that you'll see that highlights where we currently are in regards to our good areas of practice and red zones. And then we're trying to work with both to share best practice, but also to provide additional support to those that need it. I'll pause there to see if there's any further questions or comments.
Thank you, Tina. Karen.
Thank you, and thanks, Tina. As you say, we did have a lengthy discussion at People and Culture, and there's clear progress being made. I'd share your concern about the response rate, but we did discuss that, and I know that there's a number of actions in place. One of the things I wanted to pick up is the comments that you've just made about the focus on the divisions, which is absolutely the right way to go. But particularly the support that's in place, because I've noticed surgery I'm going to particularly pick up, because it's flagging red to me in a lot of areas. I noticed in terms of complaints, it's the one that seems to be suggesting is pulling things down, and all of those bits have been managed together trying to tell a story. And I wonder what focus and support is going in to that division or any other in that position where clearly something is not quite right at the moment, if I can put it that way.
sort of two lines of support that we're focusing on at the moment. One is the leadership development. It's really important to have good leaders in those areas. So we are prioritising leadership development programmes for those managers, and that's across the range of disciplines of the medical, clinical and non-clinical staff. The second part is something called team diagnostics, so that my OD team go in to support the managers in that area, leaders in that area, when you take a further diagnostics to see what's underlying, you know, sort of what the drivers are of their poor staff survey results, and then developing some more focused work with them to do some more development work, putting into their local behaviour charters and those sorts of things. So it's more focused support for those red areas on the culture heat map.
A couple of observations. One is sort of following up on results of the staff survey, and the team is very aware of this, but you have to be very careful how you follow those areas where you might have some difficulties because people might feel, oh, it's been spotted, like this is not anonymous, and seen that backfire quite badly in other places. People want to know you're handling that sensitively. I guess the other one's a slightly more frequent point is what can we all learn from digital? Because it seemed to be that everybody loved being in digital, everybody the fact, so I mean, it is slightly different, but I guess an observation or any comments can be made.
It's the leadership.
To Vicky, it's not wanting to raise it today. But we've had a conversation as an exec team on that, because it's about my point about sharing best practice as well as those areas where we need to support. And it is around using our culture journey, so our forward signature behaviours, our forward improvement system, having regular puzzles, making sure people are really clear on priorities, being involved in the changes that they're making in their areas of work. So to me, not rocket science, but it's good leadership and management is the answer.
Thank you.
And so there's a plan to try and make sure that is shared and implemented.
That's part of the, looking at the heat map and using that to have, like I said, areas of good practice that can come and talk through what's working well for them, and then sharing that across with others.
Any other questions? Vicky?
Yeah, so just really to say that as a senior leadership team, we have a really good process in place of meeting and informal touch points, but we do a digital huddle twice a week. We've also put nearly 50% of our team through the forward improvement system training programme, and actually that is starting to pay dividends for us. And we're just a really close team. We've also invested in some external coaching as well for very senior leaders within the digital division to help that succession planning piece as well.
Great, good, thank you. If there are no other comments, thank you, Tina, for that. That was for discussion, level 4. We have to move on. Great. Okay, so now we get to safe staffing, and we'll go to nursing first. See.
So technically, there's going to be some issues with the highlight. So safe staffing of the adult, children and neonate groups achieved through February 2023. Strike days went ahead in February, there was no patient safety incident related to staff identified during that period. And we have no further monitoring with significant harm reports due to staff in February, which is good. We have continued focus on our healthcare support worker improvements, because that's an issue for us, but that's resulted in 50 job offers being made since January this year, so that focus is paying off. Our vacancy factor for our registered nurses has gone down slightly, and with an associated reduction in banking agency usage. The healthcare support worker vacancy has gone up slightly in January and February, but with those job offers, we need to get that to get back. Just to highlight our international nurse recruitment pipeline, a team visited the Philippines in February, and actually resulted in 104 offers being made, including some midwives. And we have got secured monthly interviews of around 46 staff per month to take place to reach our target of 150 to 22. So those are the main
Thank you very much, Sue. Any questions or comments for Sue on nursing? No? Good. And a level 6. Thank you very much. Justine, midwifery.
Thank you. So yeah, this is the February Safe Doctor report with an insurance level 6 again, which we're pleased to be able to maintain. You'll see though that sickness, vacancy and turnover, there was a slight increase, but nothing dramatic. So we do feel that things are generally stabilised. Further reduction in escalation and increased fill rates, which is really good, and reduction in red flag reporting. You'll see there that the vacancies, as I say, are sitting around 13%. 20 of those are clinical posts and 5 are leadership, governance or specialist posts. We have just offered 24 posts to newly qualified midwives that will join us in September. So that's a really good news story. So we are, meeting the trajectory that we expected in our workforce plan to try and get to a much more reduced vacancy rate. So fingers crossed. So what we're doing, obviously, that's a huge challenge in terms of recruitment processes and onboarding people. And in addition, as Sue said, we've got 6 internationally recruited midwives that are in the pipeline as well. In addition to that, what we're doing with those 24 midwives that we've recruited is have regular touchpoint meetings with them. We've sent them a letter saying thank you for choosing us and we look forward to working with you. And we'll carry on and meet them across the summer to keep them in touch and make sure that they feel that, we're looking forward to having them in the team and a good welcome. So really that's all I wanted to say today, unless anybody's got any other questions.
Any questions or comments? Justine, I had a question. I noticed that this month there were 8 medication incidents, and that seemed a little more than I've noticed in the past. I wonder if there was, what your thoughts were about that. Is there a sort of a trend? Is there anything going on underlying?
Not that we particularly picked up. What you'll see in there sometimes are numbers of medication errors around early giving analgesia earlier, and that seemed to be a regular theme because being able to give 18, 24 hours sometimes becomes problematic for people to work out. And that isn't unusual. We're not an outlier for that particular medication problem. Within the report as well, there was an SI that we raised where a woman received the incorrect dose of Clexane, but that was not related to a staffing problem. That was a prescription error and not identifying the risks that have been identified for that woman because of her own history and also her family history. And sadly she then did go on and develop a PE, so we have raised that as a serious incident and are looking at that. So no particular themes there, but we've also noted that there is a delay sometimes in the administration of IV antibiotics for babies, and we're doing a lot of work with the team to ensure that there are more midwives who have completed their competency to be able to deliver that shortly after birth.
Okay, thank you. Great. So thank you. Also a level 6. It's good to see both our staffing on nurse midwifery at level 6. And again, some real progress there over the past year. Thank you to everyone in the team. Right, moving on. Review provider licences FT4 and G6. Is that you, Rebecca?
Yes, thank you, Chair. This is in relation to our compliance with our provider licence. As an NHS trust, it's not directly applicable to us within this year, but it is from April of this year onwards. Somewhat of a moot point because colleagues will be aware that earlier in the year we reviewed our enforcement undertakings which are taken out as a result of breaches with compliance with the provider licence. So at that point we were issued with compliance certificates in respect of several of those undertakings. A number were discontinued because of improved performance and changes in circumstances. However, ultimately the Trust is still subject to enforcement undertakings due to failure to comply with elements of that licence. Despite progress having been made, it is very much a confirmed, not confirmed answer. We're not able to say yes in part or yes but. The paper has been reviewed through Trust Management Executive, a short Quality Governance Committee in respect to the evidence that sits behind it, an audit committee overseeing the process. NHS England have also been engaged in terms of the process to review the enforcement undertakings.
Thank you. Any questions or comments for Rebecca? No. So this is something that requires approval. It's at level 5. Are we happy to approve? If not, okay, thank you very much. Right, moving on. Audit and assurance. Or anything else for our friend?
Just one issue I want to highlight, Chair, please. There's reference in the note that the head of internal audit opinion is likely to be a moderate assurance, which is disappointing, particularly given that in a number of audit areas we have significant assurance, but it's likely to be a direct consequence of that the audit report on bank and agency high earners, which was, if you recall, no reliance whatsoever. We've taken that as a trust very seriously. There's been an action plan. The audit committee has been considering that. So we're making the right sort of progress. But I think, given our initial response and the fact that it happened anyway, a slightly diluted head of internal audit opinion was going to be the consequence.
Okay, thank you. Any questions or comments? No? Okay, thank you. Yes, regrettable, but what we might do there. Okay, so moving on to TME report. Matthew.
Particularly to note, Chair, we have, as ever, a busy agenda. Many of the reports that we consider come up through the various subcommittees, and I think the key area that's worth noting, certainly from last month's meeting, is a little bit of a sense of concern from some of our clinical leaders that there is a shift in the balance that we've been able to maintain between quality and cost being two sides of the same coin, to a shift in the balance which is driven more by the financial circumstances and conditions within the wider NHS and within the integrated care system. So we're obviously just making sure that our clinical leaders understand that the two are the two sides of the same coin, and then we need to be considering both as we move forward through the year. And it plays into Richard's earlier point about ownership and engagement of the whole of the annual plan, not only the quality elements of it, the performance elements, but also the financial elements. So that's something we'll continue to keep a very tight focus on through the trust management executive discussion.
Yeah.
Thanks, Chair.
Absolutely, thank you. Any questions or comments? Great. No, absolutely reiterate that the importance of ownership. I think it's come up several times in the conversation this morning, and you know, we've got to make sure our teams absolutely engage with, commit to, and take responsibility for commitments that we make as an organisation, and that's important. So no, that's fine. Thank you. Right, moving on then, remuneration committee terms of reference. Rebecca?
Yes, thank you, Chair. This is part of our annual review of terms of reference of the board subcommittees and tied out open committees of the work plan to make sure that terms of the work plan deliver the terms of reference agreed by committee. So you'll see those coming through for the supporting committees as that work plan review is underway. There's just been some minor housekeeping points made to terms of reference, which are substantively the same, and also just to note that the Audit and Assurance Committee, in terms of reference, are looking at the audit report, so we've just received the board's approval of those. They've both been reviewed and approved at committee.
Great. For approval, level 6, any concern? No? Great. Thank you very much. Thank you, Rebecca. Right, any other business?
Just one from me, just to note Michelle Lynch's apology.
Thank you very much for that.
I've got one, Chair.
Please.
Just to note that having given me the opportunity of trying to live broadcast this first board meeting in person, it appears that that's happened successfully this morning. But I would particularly like to thank, sitting behind me, Glenn Mannion from Team Communications and Newman Hussain from Team Digital, who put in an enormous amount of preparation to get the kit working and linked to the network and functioning over the last 2 months. and also monitoring will be remotely. Peter Orton and Team Comms is making sure that it gets broadcast to the outside world. So just like to express my thanks to all three of them, please.
And that's absolutely echoed by the board. Thank you very much to the whole team. I think that it adds another dimension to our capabilities effectively. It means that we don't have to meet in teams in order to get these meetings out to the general public. So yeah, I've no idea what it looks like from YouTube, but certainly from our experience here, I think it's been very unobtrusive and if the feeds worked well. So congratulations and thank you very much for everyone that's been involved in that.
Thank you.
If there are no other questions or comments or any other business or anything else, I would like to thank everyone for their attendance today. Oh, sorry. Oh gosh, should we go straight to trustees? Yes, absolutely. Yeah, next one. Trust board trustees. These are the trustees of our charity. There we go. I've got it. Perfect. Lovely. So we have got apologies for absence. I won't repeat them. We've got them already. Declarations of interest. Again, they're on the website. Not notified of any additional declarations. Minutes of the trust board as corporate trustee on the 9th of February. Are we happy that's a true record of the meeting? Thank you very much. Moving on then to the report of Charitable Funds Committee. Simon.
Thank you, Anita. I'll take the report as read. Just highlight a couple of items for you. One is there is an open invitation to you all to attend our Charitable Funds away day, half away day on the 18th of May. I know that's been circulated, but you can more than welcome to come along and reflect on the strategic direction of the charity. The second one is for the personal pleading. Some of you know I am doing the Northern Hills NHS 75 walk in aid of the maternity unit, maternity services. History going back there to the 7th of May 18 years ago when I was born at the maternity unit and obviously been the maternity safety champion for a little while. And if anybody likes to sponsor me, they've been more than welcome. Just kidding, Simon. But otherwise, thanks so much. Any questions?
Thank you, Simon. Any questions or comments for Simon? No?
Just to add to Simon's comment, Chair, this is the first year that the charity's been in, had people entering the Northern Walk, and we've sold out all the places and been so successful actually that we've had to hire some additional transport to get people to and from. And have also sold out all the charity places in the Worcester City Run as well. So both very positive, and hopefully that will generate some significant income from the charity. Simon's talked about the away day, but also worth noting, given the conversations about staff wellbeing, that we are going ahead with Wellbeing Matters Day on Tuesday the 16th of May. And again, we're expecting a good turnout of colleagues from all parts of the organisation to help us further map out the wellbeing support that the charity can offer over the coming months and years.
Thank you very much. Absolutely, and that's great to hear about the take up of the charitable events. And yes, it was remarkably easy to respond to you, Simon. So certainly about for that. But yes, the great stuff. Thank you very much for your work. Okay, I think I can now say that we can now conclude the meeting of the board in public and the meeting of the board as corporate trustees. Thank you very much for your time this morning. I can't remember what the date of the next meeting is. Do we have that somewhere? Is
11th of May.
Thank you. We meet again on the 11th of May. Thank you very much for attending. See you soon.